Okay, my name is Bonnie Flemister. I'm a geriatric nurse practitioner. What you need to know about me is that I don't work in some university or sit in some ivory tower and make up rules for y'all to follow. I do what you do, okay? I started going to nursing homes to help take care of residents in about 1983, okay? I don't have a bit of problem with, I'm a wound ostomy continence nurse, so I have no problem cleaning up people. I have no problem helping you feed your residents. I just tell you this because I want you to know I know what you do, okay? The state has come in and given you a no, that was not a good thing, a deficiency, and it was about psychotropic drugs. So the background history of this is that they do not want residents to have what's called chemical restraints. Okay. And this comes from the Oprah Act in 1987, which is the Omnibus Omnibus Breakthrough Reconciliation Act. Okay. And up until that time, residents in nursing homes didn't have much freedom or much ability to take care of themselves, okay? In other words, it was not uncommon at that time for residents in nursing homes to be given medications to make them sleepy. They stayed in bed just about all day long. They didn't really have any activities. Okay. So what it did is it specified that that residents would be free from physical and chemical restraints for the purposes of discipline or convenience. And you can imagine that if you weren't a dedicated nurse, and I'm sure that there weren't many nurses working in nursing homes at that time, to just give someone a pill, have them stay in bed all day. Okay. So nursing home residents were over-medicated and excessively restrained. If someone was a wanderer, they just tied them up in the chair or tied them up in bed. And many residents received psychotropic medications or antipsychotics without any indication. It just kept them quiet. So the intent and the purpose of this requirement is so that each resident entire drug and medication should be managed and monitored to achieve certain goals. And those goals would be the medication actually helps promote and maintain the resident's highest practical, hear that, practical, mental and physical and psychological well-being in collaboration with the doctor and, of course, nursing, I think. And that residents receive only those medications in doses at the time necessary to treat what their condition is. And that non-pharmacological interventions such as behavior interventions are considered and used when indicated instead of just throwing a pill at them. So unnecessary drugs, and this is specified by Medicaid and Medicare, and those are excessive dose, which means any duplicate medication, or excessive duration, given it longer than it's needed, without adequate monitoring or without adequate indications for its use, or in the presence of adverse consequences when indicate the dose should be reduced or discontinued, okay, or any combination of the above. When I first started working in nursing homes as a nurse practitioner, I was the first one in Tyler, Texas, first nurse practitioner to go into nursing homes. Okay, I looked and I would look at medications, and sometimes these residents would be on 3 different kinds of, you know what I'm saying?
Psychotic medicine.
Yes, you know. Or 3 different kinds of medications for constipation. You know, I mean, just different things. And the reason is because the nurse would call the doctor and he just threw a medication at it. You know, or the doctor on call didn't know what the resident already had. Okay, and so you can imagine the problem. So what are psychotropic medications? They're drugs that affect brain activity. You hear me? They affect brain activity And those are antipsychotics, anticonvulsants, anti-anxiety medication, hypnotic meds, and antidepressants. All those drugs mess around with your brain. So why am I bringing up antipsychotics first? Well, first of all, Texas is the second highest antipsychotic use in nursing home setting in the United States. Okay. Think about that.
Which is
That's us, y'all.
Which is the first state?
Huh?
The first state. The number one state.
Out of the 50 states, we're the second highest. Only one.
Who's the first?
I don't know,
Oh, okay.
but I'll look that up. Is my husband in here? I'll have him look it up. But thank you for asking. Antipsychotics have the strongest evidence for negative consequences when used in older individuals, especially those with dementia. We'll go over that. And the FDA has warned all medical professionals that using antipsychotics for your residents with dementia is a risk for possible death. So what are they? Emphasis is in reducing the inappropriate use of antipsychotic to treat behavior. Okay. And so that's Abilify, Haldol, Zyprexa, Seroquel, Risperidol. So what is psychosis? Psychosis is impaired relationship with reality. You don't know what's really real out there. Or and it's a symptom of serious mental disorders. People who are psychotic either have hallucinations, they see things or hear things that aren't there, or delusions, they think that something's going on that's not really going on. So here's what happens. This is how your brain cells communicate. You have different brain cells, thousands and thousands of them in your brain, and they send a message from one brain to another. See down here in the corner? Okay. There's those two brain cells, and then there's those little neurotransmitters or little chemicals that carry an electrical impulse. Okay. So it's the neurotransmitters I want you to pay attention to. So what happens is, in an antipsychotic medication, those neurotransmitters, they interfere with that actual message going from one cell to the other. Okay. And that stops someone who's having the wrong kind of transmission. Okay. So antipsychotic medications interfere with the neurotransmitters, what the message going from one cell to the other. So antipsychotic side effects are, it gives you low white blood cell. That's your immune system, y'all. And then you can get risk of sudden cardiac death, tremor. Okay, makes your residents have tremor. Their muscles get rigid. They have muscle spasms in their tongue, mouth, and back, and sometimes you'll see them drool. You know what I'm talking about. Sedation, it makes them sleepy. They get confused. They risks delirium. And then a fall risk. Okay, and that's one of the biggest things we worry about in nursing home care is our residents falling. And then constipation, urinary retention, dry mouth, and blurred vision. All of those are the kind of things that we really are concerned about with our elderly residents. And they're restless, and sometimes they can't have an inability to sleep. So, approved diagnosis, CMS sets the approved diagnosis for antipsychotics, and those are the usual mental illnesses: schizophrenia, delusional disorder, mood disorders, which is bipolar, manic depressive, Huntington's disease, which Huntington's chorea is hereditary, and they have a lot of trouble with coordination. And then Tourette's syndrome is a disorder which is people say things that they don't intend to say. And then any of the above. So the risks of that is that worsens dysphagia. So if you have, a lot of our older people have a problem swallowing anyway. And so these kind of drugs make it even more difficult for them to swallow. And then what happens is we alter their diet, chop up their food, sometimes put them on thickened liquids. And if y'all have ever tried that, that's no wonder they don't eat. You know. An increased risk of aspiration pneumonia and upper respiratory infections. You know, we make about a quart of saliva every day, okay? And if we can't swallow it, then it goes down into our lungs and gives us aspiration pneumonia. Increased risk of urinary tract infections that contribute to delirium, and that's a whole different lecture. And an increased risk for pressure ulcers because they're not moving around. So anti-anxiety and hypnotic medications can be used as potential chemical restraints. You know, if they're moving around and we can't keep up with them and they're going in other residents' rooms, okay, we try to calm them down, and that's for our convenience. And then they're subject to the same standard as antipsychotic drugs are when it comes to monitoring and care planning. And they're indicated for long-term scheduled use for diagnosis of primary anxiety disorders, okay, not for what's going on temporarily. Okay, these are anti-anxiety medications, or otherwise known as tranquilizers, and most of them are benzodiazepines, and they provide temporary relief, but they have side effects and safety concerns that we need to be thinking about. They're not a cure. They didn't cure anxiety. And here's the thing that I found impressive, is that in 4 to 6 months of regular use, they don't work anymore. So if you have somebody on a benzodiazepine, Xanax, for anywhere from 4 to 6 months, in that amount of time, if they use it, then it's no longer effective. And they work by slowing down the nervous system. So those things are Xanax, Klonopin, Valium, Ativan. And the side effects, of course, are dizziness, drowsiness, poor balance, slurred speech, trouble concentrating, memory problems. That's just what we need with an older person, is memory problems, isn't it? And then confusion, an upset stomach, blurred vision, and headache. Those are all common side effects from benzodiazepines. And they're also a great fall risk. So the use of anticonvulsants, this is new, okay. They have chemical restraints. They're considered off-label as mood stabilizers in dementia care, and they're subject to the same standards as antipsychotic drugs. Hypnotic medications, okay, we'll see those a lot, and they're out in the community, okay. People who can't sleep. There's Ambien, Dalmane, we get that in here in nursing centers, nursing homes. Restoril, Lunesta, Sonata. And the problem with those is they have burning and tingling and changes in appetite. Sometimes it makes you eat too much and sometimes takes your appetite away. Some people get diarrhea, some people get constipation, dizzy, dry mouth, daytime drowsiness. One of the interesting studies that was done not too long ago on Ambien is that women's metabolism is slower with Ambien, and so giving 5 milligrams of Ambien to a female is the equivalent of giving her 20, okay, 10 to 20. And I've seen cases where people who are on Ambien, they'd get up in the middle of the night and go to the refrigerator and get food out and eat it and not remember what they were doing. Sleepwalking. Okay. So, I'm sorry, I skipped over. We were talking about anticonvulsants, and those are Depakote, Lamictal, Tegretol, and they can be used for bipolar disorders. Now let's talk about dementia. We just got through talking about psychosis. Dementia is something else. These are cross sections of the one over on the left is a normal brain. The one on the right is the brain of someone with dementia. with Alzheimer's. That's an Alzheimer's brain. You can see that the tissue is gone. It's not there. It isn't a matter of transmitters, from one cell to another cell and messing around with the transmitter. There's no cells there. So it's a permanent degenerative change. Once they lose those cells, they never ever come back. It's a lack of acetylcholine, that's because it's gone. The beta amyloid plaques that cause inflammation and cell death, and then they get protein tangles. And then there's psychosis-like symptoms seen in dementia are unlike the psychosis in mental illness, like schizophrenia. Okay. In schizophrenia, the brain's all there. They're just having problems with the communication from one cell to another. In dementia, the brain cells are gone. And the reason why one dementia patient isn't like another dementia patient is because you don't know which part of the brain is gone. Okay. So one may not be able to express themselves and forget what's going on, where somebody else is having problems with just memory. So dementia doesn't involve neurotransmitters, and it doesn't involve the nervous system. So the antipsychotic challenges for dementia is the behavior disturbances tend to be sporadic, okay? And eventually, the lifespan of someone with Alzheimer's from diagnosis to death is 8 years. Okay? And you need to remember that if someone has dementia, they're going to be different from 1 month to the next because more and more of their brain cells are going to be gone. Antipsychotics are likely to be prescribed with comorbid conditions and many medications. Okay, they just throw another pill at it. Antipsychotics are more likely to be prescribed for those already on psychotropic medications. They just keep adding it. If they're on a benzodiazepine, then they give them something to make them sleep. And then over time, antipsychotics are barely more effective than a placebo. So dementia is unapproved off-label. CMS, the Medicare, recognizes that antipsychotics are usually started in the hospital or in the community setting. When someone comes in here and they're on an antipsychotic, it's because they've been prescribed that at the hospital because they couldn't keep them quiet, or they were at home and the family wasn't able to control. So it's your responsibility that when they get to the nursing home to evaluate whether they really need to be on an antipsychotic. Are they really psychotic, schizophrenia, or bipolar, or do they have dementia? And then evaluations for continued necessity must be in the clinical record and on admission within 14 days after admission. So y'all only have 14 days after somebody comes in on an antipsychotic to find out whether they're really psychotic or whether they have dementia. So unnecessary drugs cover up needs. The resident can't express when they're in pain or they're uncomfortable. They can't be understood, which they probably can't be understood anyway. They have problems with toileting. They can't tell you if they're hungry or if they're thirsty. They can't make their own decisions, and they can't do their activities of choice. And they've lost their independence. So how to get started? Well, you need to evaluate whether they really need any medication, not just antipsychotics. Do they really need to be on this drug? You identify all residents that are on antipsychotic medications. You determine which antipsychotic medications are really appropriate. You implement a gradual dose reduction as needed and indicated. Okay. And that's probably going to come from your pharmacy consultant, because doctors don't know. Okay. And then you manage the unmet needs and the behavior through some kind of improved dementia care using person-centered interventions and treatments, and that's a whole different program too. Okay, there's a lot of things that you can do. You can distract a dementia patient. Okay, it's real easy. Take them by the arm and say, let's go get a cookie, or let's go get a cracker, or let's go get some tea. Okay. Strategies for success, you have to target their specific behavior and then monitor for the presence of what behavior and what the side effects are of any of those drugs. Monitor the residents for changes in cognition and function, and document non-drug interventions implemented and their effectiveness. Okay, if you give them a drug, you need to say whether it worked or not. And then periodically at least evaluate, and state says at least quarterly. So you need to eliminate the barriers. What are your perceived notions and fears? If you have somebody on an antipsychotic, what are you worried about? Okay, if we begin to taper it. Do you accurately document their behavior? Do you educate and inform family members? Sometimes family members get, I used, when I was taking care of residents, the residents were usually easy. It was the families that I spent most of the time trying to solve problems. And when the internet came out and they could look up drugs, I nearly died.
Because they know everything. Sure.
So the dementia, they need to know what the dementia process is. They need to know that brain is going away, and what the benefits and risks of any medication that they're on. If you start to take them off their Xanax and they get all upset because mama's been on that for 15 years, and it's the only thing that calms her down. And then consult with the pharmacist's recommendations. Pharmacy really knows what they're doing. And discuss the goals with the resident and the doctor and the consultant pharmacist. So sometimes it's hard to interact with the doctor and the pharmacist, and physicians may not be up to date. Trust me, they're not. Okay. And primary care physicians may feel awkward about changing medications. Okay. I've been there, you need to tiptoe around that. And sometimes your clinical pharmacist is the best one to communicate with the doctor. Psychiatrists may feel threatened with possible consequences of reducing prescribing. That's how they make their living. Okay, and pharmacists may feel threatened when making recommendations. You've got an old cranky doctor, and the pharmacist doesn't want to deal with him either. Okay. So there's gradual drug reduction. You need to titrate the dose down and slowly over 1 to 2 weeks. And here's an important thing, is the staff should know, every one of you should know that that's what's going on. And that when you start to reduce the medication, there's going to be changes, okay? But that doesn't mean they're permanent changes. It's drug withdrawal. It's like y'all, if you've been drinking a cup of coffee every morning with your breakfast and you quit drinking coffee, okay, you're not addicted to that caffeine, but your body's dependent on that caffeine, and you're going to have headaches and have problems. And then use non-medication interventions and treatments, and then keep documenting and communicate other staff members what does and what doesn't work. Okay. We need to talk to each other more. Okay. If you know how to calm down a resident when they get upset, you need to share that with another staff member. Okay. That this is what I do, and this seems to help. Or you can say, I don't know what to do with Miss Jones, but she seems to cooperate with you. What's your secret? So consent for psychotropics, I'm not going to go much over this because the Texas law states what you have to do. And there's a rule, of course, and most outline the condition being treated, and they tell what benefits you can expect and what the significant side effects are and how long you should treat them. And the right to revoke, that needs to be in writing. And refusal of consent must be documented in the clinical record. So the guidelines for dementia is remember that there's no FDA-approved medications for the treatment of psychosis and behavioral disturbances of dementia. There's no drug. There's no psychotropic drug that helps with dementia. Psychosis is a symptom, not a final diagnosis. Okay. And then impaired memory is easily mistaken for psychosis, and not all delusions are psychotic. Okay. You know that with your dementia patients. You know, they don't remember who their daughter is, or they think somebody else is, they're somewhere else, you know, and they've got to, you know, I was talking to one lady once, and she was in the Alzheimer's unit, and she sat there and just carried on the most wonderful conversation with me. I mean, we discussed all kinds of things, and I thought, I wonder what she's doing here. And then she said to me, honey, I hate to bother you, but I've got to get the children off to school. Okay. So monitoring behavior, delusions are common. About 40 to 50% of patients with Alzheimer's disease have delusions. That's what she was having. She thought that she had to get her children off to school. You must assess the resident for behavior that requires intervention. Sometimes if they're walking around, you know, just let them walk around. Like, for instance, maybe you found out that Grandpa just, you know, he's always pacing the floor after lunch. You can't get him to settle down, and he really needs to go lay down and have a rest. And then you find out from the family that he used to go for long walks after lunch. Okay, that was his normal behavior. He enjoyed walking and being outside in particular after lunch. And so that's ingrained in whatever part of brain he has left. Determine if the behavior is permanent or transitory. I mean, is this something that's just happening right now? And then you determine if the behavior has been evaluated for possible or social or situational crisis. Okay, maybe they found out that you know, the family came in and said the grandson has moved out or something like that, and you don't know about it. Environmental causes have been ruled out. Mental causes have been ruled out. The symptoms are persistent and not caused by preventable reasons. Okay. So you need to get the information, include your physician, your pharmacist, your nurses, your aides, your social worker, your activity director, and get even housekeeping. Housekeeping a lot of times can give you clues because they see things that you don't see. I mean, one of the things I always said that I teach, and I did, when I went in to assess a resident, I would stand outside the door and look in and not let them know I was there right then. And sometimes you can pick up all kinds of cues about what's really going on. You might have someone in pain and they look like they're grimacing, and then you walk in the door and they're all happy. You know, they don't want to bother you. Okay, you've got enough to do. You're a busy nurse. I can't bother you with my little problems. Or it can be the other way around. You know, they're laughing and happy and reading the paper, and you walk in, and all of a sudden it just, okay. And another thing is maybe someone in the dining area notices that a resident is limping, okay, and you didn't notice because when they walk to the room, they're holding on to the handrail. And then get input from family members because behaviors might be misinterpreted from the person's past experiences. Like I said, Grandpa walking around after he has lunch. So the importance of documentation. Do I have to beat you over the head with that? If you just document. The permanent record is the key healthcare facts. That's what everybody's going to read. Okay, that's what lawyers read. Okay, is what's in the record. Excellent nursing practices for patient safety. What kind of a nurse you are will be what's written on that paper. Core of every resident's encounter, the history of nursing services that were delivered. Okay. And I know I don't like to document either, but there's just times when you have to do it. Okay. And the form of communication with other healthcare personnel. It's the only way that sometimes that afternoon shift is going to find out what happened right before evening shift came in. Okay? It's got to be in the record. It's the only way you know whether a med was given or not. Okay? It's the only way you know whether someone's daughter came to visit. And then determines the basis for future decisions. And then the quality reporting, the public health and reimbursement. Okay? If it, as much as it drives us crazy, if it isn't documented, it wasn't done. Now, I don't believe that, and you don't believe that, but there's times when that matters. And then the best evidence that the staff members have adhered to the standards of care. Okay. I read law cases, okay, in defense of nursing homes. Okay. And you would be surprised how important it is when I look through there to see if you did what you said you were going to do. Okay, even check marks, that's why we have so many, but check it. Okay. And then pre-psychotropic documentation, you need to target the behavior and say what the problem is. And then you discuss the interventions and approaches with all members of the team. And then you document any person-centered, non-pharmacological interventions.
No. I need a 200 hall nurse. A person is discharging and needs her medicines.
Careful.
Guilty.
A psychotropic good. Okay, so you target the behavior. Without documentation, there's the potential that the psychotropic drugs were viewed as a chemical restraint. Okay, if you have to give a psychotropic drug, you need to say in your documentation why they're getting it. When antipsychotics or psychotropic drugs are prescribed for behavior, there's a possibility of keeping them unnecessarily longer than needed. And when an antipsychotic drug is used for behaviors, it can cause significant distress or harm to self or others in unapproved or off-label diagnoses, such as dementia. Documentation is especially important. Okay. So, there's a black box warning, which is the biggest warning of all, the FDA. If you ever see something with a black box warning, you need to be really, really careful before you administer it. And what that black box warning says is elderly patients with dementia-related psychosis treated with an atypical antipsychotic drug are at increased risk for death. Now if you give that and you haven't documented it, someone somewhere might say that you contributed to that resident's death. So your responsibility as a nurse is you are liable for your actions and omissions, whether you gave the drug or didn't give the drug when it was scheduled, and for duties that you delegate to others. And then you're personally responsible legally, morally, and ethically for every drug you give, or every drug you ask somebody to give for you. Your nursing responsibilities include you need current knowledge on your base of drugs. Where do you give it? When should it be given? How it should be given? And you need a professional source of to get that information about those drugs. If you have a PDR out at the nurse's station that's older than 5 years, it's no longer valuable. Fortunately, with our cell phones, we can look up. Questioning a drug order that is unclear or that appears to contain an error. Okay. Refusing to administer a drug if there's a reason to believe it will be harmful. Okay. Performing correct techniques and precautions. And monitor the client's response, and you document the drug's effects. Okay. We're really good about antibiotics. I've noticed when I'm reading law cases, we're really good about antibiotics with no adverse effects. But we need to be really more careful about other drugs that we give. And especially if it's a new drug. Okay. Patient and family education. Okay. I want to thank you for your time and attention. And do you have any questions?
So, well, maybe a question to Christine. So does that mean we're gonna start cutting down on some of these meds, or how are we gonna go about that?
Well, our responsibility as nurses is really not to cut down drugs immediately because we're not doctors, we're not the prescriber.
Yeah.
Because if you notice something, it's your responsibility, because I'll take you back to the history or the background of all this. When the state came in here, we have residents on hospice. We have reviewed all our charts. So residents, when they're on hospice, guess what happens? Hospice has a comfort kit, there's Xanax, there's Ativan, there's Haldol, there's morphine.